We shall now go on to our next speaker, Dr. GIRISH, who's heads the Shankar Netralaya Administrative Section and also a senior consultant of the Vitreous Retina Services. And he's going to be talking on some very challenging talk. How do you structure your CME programs with an objective? On to you. A difficult talk. Let's see how you're going to do it.
So it is said that when you speak, you only speak what you know. But when you listen, you actually get to learn new ideas. And I am thankful to ARC and Dr. Chitra for making me a part of this session where I could listen to a lot of innovative ideas from the speakers. I agree that this CME is difficult. As a retina specialist, treating a CME is not that difficult for me. So I had to scratch my brains trying to look at material for coming out on structuring this talk, and this would be the scope of this talk. So this National Academy of Medicine defines continuous learning health system as one in which science, informatics, and culture are aligned for continuous improvement and innovation, with the best practices seamlessly embedded in the care process, and more importantly, patients and families active participants in all elements. I think that's one important factor that we tend to overlook. And so that all this new knowledge is captured as an integral byproduct of care. So we need to understand that whatever we do in our activities, in conferences, CMEs, ultimately we want to make it deliverable as a best care for the patients, improving the patient experiences. Now in a healthcare organization, we all need to look at the triple aim of an organization, and that's basically to improve the population health, effectively use the available healthcare resources, and ultimately give patient the right experience while taking care of their health. So as Avinash said, medical education typically has 4 years of undergrad training, followed by 2 to 3 years of residency, followed by fellowships in some cases, and then you could even have super specializations. What is very important during these is the importance of hospital rounds. So now most of the present day institutes probably do not have this, more so post-COVID, where ophthalmology is now moved to a daycare. So most of these now tend to be only outpatient care kind of situation. But one cannot underplay the importance of hospital rounds that have helped in mentoring and teaching all the postgraduates and undergraduates, journals, meetings, and conferences. So this has been what conventionally has been the teaching modules. But the fallacy is we as doctors, we believe that we accurately can assess what our learning needs are, or in other words, where we are lacking. We do not look at data to understand what is the prevailing practice pattern within the organization or within the society or within the area where we want to have this program. There is no objective way of analyzing the performance of the target audience. One of the major drawbacks of didactic lectures are it's one way. And a person comes, delivers his lectures, and it's just assumed that the audience is receptive and has imbibed everything that has been spoken. And ultimately, at the end of the session, we get credit hours or countings of points, which can help us in our program. So ultimately, what we should be looking at is, like what Dr. Ravindran said, that we have to look at innovating education. So look at ways in which you can make it more interactive, make it more easily accessible to people. It need not be a physical, in-person kind of training. It could even be through podcasts, videos, simulation-based centers, or even as in COVID times we have learned very well that even online education is an excellent platform for dissemination of information. So there are ways of innovating so that the same deliverables are given at all times. Now, here comes in the role of a professional within an organization who would be mentoring this CMA program. And it's very important for that professional or that person to know what are the gaps in that particular organization or that cohort of people who are going to be the beneficiaries of a CME, and have theory and evidence-grounded educational activities which are tailored to the context, culture, and which is very specific to that particular health enterprise or that particular group. And that's where this model of plan, do, study, and act comes in play. So as I said, data is very important here. And unfortunately, in India, we do lack, because there is no national data of health. Each of us have our own electronic medical records where we can look at our own needs, but there is no way an All India Ophthalmic Society or a Vitreoretinal Society can actually access the data of all the members and try and find out what are the deficiencies, which are the areas which require more an approach. So once you analyze the data, then you can actually look at what are the deficiencies, look at the ways in which you can overcome these through tailor-made programs, which could be short courses or over a series of training programs. And then you also end up having measures so that whatever has been intended to deliver can be in form of measures. Again, the data is very important here. Which then brings us to how do you choose a theme for a CMA program? So it could be anything. It could be a new theory. So something like in ophthalmology, in retina, we have suddenly come out with pachychoroid spectrum of diseases, which is conventionally different from what we were initially thought. So this is a new theory, and you could have a CME just looking at that particular spectrum of condition which purports a new theory. It could be a new drug, a new intravitreal injection, or a new glaucoma drug, or a new dry eye drug, which is very innovative, has a different mechanism of action. So that could be a CME which is tailor-made just for that particular activity. It could be a new investigational tool, like a OCT angiography, or one of the corneal topographers, or a IOL measuring technique. So you could have many tailor-made CMEs for a particular investigative process. It could be a new surgical concept itself, like if you have something like the scleral fixated IOLs, or complex surgeries for a persistent macular hole, where people have now started doing a retinal grafting. So these are all very specific CME programs which are tailor-made for that particular activity itself. Research, India is lacking this. There are institutes which are trying to make a difference, but again, one way of motivating people to take up research could be through targeted CMEs on this activity itself. And obviously for the postgraduates, you could have exam-oriented CMEs itself. So ultimately what you need to know is what's your target audience. So as I said, when you are looking at resident programs, you are looking at subjects which are more basic, which are more targeted toward either enhancing their knowledge or their approach to exams. Private practitioners, I would hesitate to have a CME on flax, the femtosesteroid, for a general practitioner. Whereas for institutional practice, it's more tailor-made to whatever new technology that's going to come into the system. Or it could be a subspecialty kind of program which looks at that particular cohort of practitioners. Like you could have people looking at intravitreal injections, the latest, which would be of interest to a retina specialist and for some of the medical retina specialists. Of late, also interdisciplinary CMEs are taking importance. So we know that while we're treating patients with diabetic retinopathy, there is an interplay with a physician. Or if you're looking at ocular oncology, you also have the radiologists and the oncologists coming into picture. So interdisciplinary CMEs which are focused at a particular thing. Ultimately, what needs to be looked at is how do we move away from just assessing the impact of a CME purely based on credit points. What would be probably important is to look at pre and post CME assessment of the knowledge, and not just look at commitment to change, but actually measure that change. either in the processes or in the outcomes. And I think for this, it's very important that there should be mechanism of monitoring the patient outcomes on a national level. So ultimately, one should understand that CME is a lever for improvement rather than viewing it solely as a means to help physicians meet their licensing or credential requirements. And it helps to tackle complex problems and translate evidence, the what and the how, into clinical practice. That is, how to do the how. Ultimately, and most importantly, it holds great promise for improving patient and the population care. Thank you for your patient listening.
Thank you very much, Dr. Girish. That was a very difficult talk, but the challenge continues to remain. Like today, I had structured a very nice program, but I'm challenged with the audience. And I think if you have a full hall, the amount of energy a speaker has to convey to the audience is entirely different if the hall is. So I think there are a whole lot of limiting factors: inability to get leave from the place of work, the cost of travel, the cost of accommodation, I don't know, whole range of things put in. So I think maybe CMEs at a local levels, like city levels or state levels, if they are structured very well, would have a better reach for the local audience.
Exactly.
Than probably something like this, which...
and that's happening to an extent. So most of the, especially in ophthalmology, you have now
a lot of programs happening.
Programs which are city-based itself.
Yeah.
So,
but some of these programs are actually, it is my disappointment about many of these programs. People send their topics forward, and those topics are put together and assembled, and in a very short, brief manner, it's put together. So the idea was that how we take up a program and how do we structure it, and as you beautifully said, it has to be based on the location, based on the need, and based on the newness of the topic. But I think CMEs have to be taken a lot more seriously and done justice to. I'm sure people like Dr. Grover and Dr. Meenu and Dr. Saurabh and Dr. Praveen and Dr. Shreya would do a great job. But we have all those great organizers here. I wanted many more in the audience who would learn and go, which did not happen today. So, thank you very much. You have anything to ask him?
No.
Dr. Meenu, would you want to ask him something before you go on to the next speaker?
I won't consider it as a hindrance, that is the less attendance.
Yeah.
Because thanks to post-COVID era, that it has taught us how to record these sessions and send them individually, mail them, blast them.
Yes.
And
We
I
will
think
do
that kind of reading is more because it comes in your library. Because sometimes we might listen and we might forget. But getting it up in your laptop and keeping it and storing it, I think that's one thing which COVID has taught us, and we are definitely going to do that from ARC. Thank you, sir.
Yeah, because listening to the whole program may not be interesting to many people.
Yes.
So they are people are specific now.
Yeah.
So they can have this in their laptop, wherever, whatever, and accessible at any point of time.
Yes.
And so this is not a loss, madam. Don't think
Yes.
that people
Yes.
won't listen to this. Many hits will come later on, and it will be well
We have
taken.
No, I
thousands of
wanted
viewers
the
post
best for my speakers.
That is true. That is true. But that is again another point. See, now we have also learned over 2 years to look at a blank screen and talk.
Yeah.
So that is not at all a
So
big
this is
deal.
a
But
much
then in a
better
hall,
change.
when you're sitting in a hall, this is a very valid point that you
Yeah.
will be looking at empty
It's like a
chairs.
news anchor, sir. You don't know how many people are actually watching it.
And
But
you'll think-
thousands and lakhs
You
of
can
people
happily
might
think
actually...
that the whole world is looking at you. What is the problem?
Exactly. Next.
Thank you very much.